Good morning, everybody. Welcome to PCH Grand Rounds. We're going to go ahead and get started. We have three speakers this morning for what I think is going to be a very interesting and timely presentation on clinical informatics. Our speakers are Dr. Abbaszadegan, Dr. Christopher Hollweg, and Dr. Andrew Muth. We'll introduce them in order that they're coming up. Dr. Abbaszadegan is the Chief Health Informatics Officer at the Phoenix VA Healthcare System, and he is the Program Director for the Clinical Informatics Fellowship Program at the U of A College of Medicine at Phoenix. Dr. Christopher Hollweg is a fellow in that program, and he recently finished his pediatric residency in Staten Island, New York at Richmond University Medical Center. And our third speaker is Dr. Andrew Muth, who is also a fellow in the Clinical Informatics Fellowship at U of A, and he recently completed his pediatric residency here at PCH MMC. So please welcome Dr. Abbaszadegan.
Good morning. Thank you for having me. This is honestly a great honor for me to be giving grand rounds for pediatricians. And this is exactly why I love the field of informatics, because it really doesn't matter what your primary specialty is. What matters is how you use information to redesign and change how we deliver healthcare. So let's get started. We have no disclosures, the three of us. This is the overview of our presentation. We're going to talk about the field of informatics, the role of the physician executive, projects, the future, and a little bit about our fellowship training to see if I can solicit a few of you to join us here in the future. So the objectives today, we're going to describe the field of clinical informatics, recognize the impact that informatics has on your field, and evaluate and discuss some of the projects and work that our fellows are doing to help you get a better idea of what it is that we do. Speaking of which, what we do not do, we are not IT. We are informatics. So we do not know how to fix your cell phone. If your computer crashes, I'm actually probably one of the worst people to ask what to do. So we are not IT. So right off the bat, make a clear distinction. So the fundamental theorem of informatics once upon a time was this, that the computers are taking over and the computer is better than the human mind. In fact, that is not the case. But let's pause for 1 second. Can anyone tell me, fast forward to today in modern age, what is the fear of today? Who or what is taking over? Anybody? AI, thank you. Yes, indeed, artificial intelligence. So the last time we did an informatics event at the university, I swear there was at least 3-4 med students that were almost in tears that AI was going to put them out of work and they were going to die poor. That is actually not the case. This is actually the case. The computer, what we call clinical decision support or clinical decision support system, getting you the right information at the right time, at the right moment when you're about to make a decision, is better than just your mind alone. So it's a supplemental. So information is used to enhance your work, not take over your work. This is another point of view. I also like this slide a lot. We look to see what's worthwhile. So a common example I use are Fitbits. Who has a Fitbit? Raise your hand, be proud. Okay, good. So Fitbit can monitor your heart rate, which we've now found out is not entirely 100% accurate, but the manufacturers will tell you, you can get this heart rate, you monitor it, it goes up to the cloud, and then there's a doctor sitting on the other side, and all they're doing is sifting through your heart rate data. So engineering-wise, yeah, we can make something that will track your heart rate, but everybody in this room knows that there really is not much clinical utility in that unless you're within seconds of calling it a day, or a life, I would say. So we are kind of at that in-between. We understand the digital world, we understand the IT world, and we try to make their clinical relevance present and help us all use information and digital tools to enhance how we practice medicine. So these are kind of all the different things that touch informatics: genomics, telemed, big data, health information exchange, patient safety. There's a lot of implications for that in our field. So without further ado, we will jump to your very own Dr. Andrew Muth. Thank you.
Well, thanks so much for having me. It really is a pleasure to be back and see so many familiar faces and be the one speaking up here. So it truly is a pleasure. We wanted to describe some of the projects that we've been involved in. and we think that will be applicable for the pediatric field. But first, my first project is going to be discussing clinical decision support. So I wanted to briefly give you an overview of what that is by starting out with an article from the Bulletin of the World Health Organization that's discussing the clinical implementation gap. This essentially is the difference between where our current scientific knowledge is and the difference between that and where our patient care is at. So our job as informaticians is to help close this gap because historically it takes 17 years to go from scientific knowledge and translate that into quality patient care. So clinical decision support is one of the tools that informaticians use to do this. When I was a resident, I really didn't have an understanding of what CDS was, but you really see it every day in your practice. So whether it's an order set, a note template, an alert saying that the patient has a certain allergy or a drug-drug interaction. That's kind of what CDS is. As Dr. Abbaszadegan went over the 5 rights, our job is to get the right information to the right person, the right format and channel at the right time in that person's workflow. So this is an example of the ketogenic diet order set and some alerting associated with that to the physician or other providers. So that's my first project that I'm still currently involved in with working with Vinay on. And essentially the problem is that a lot of these kids are on the ketogenic diet because of they have refractory epilepsy. So if you're introducing dextrose-containing IV fluids or you accidentally put them on a regular diet, you could induce or take them out of ketosis and possibly induce a breakthrough seizure. So those are kind of more obvious dextrose fluids, regular diet, but where my project focused on was identifying the carbohydrates or the glucose in common medications that we prescribe every day on the inpatient side at least. So things like suspensions, elixirs, chewable tablets. So I thought this would be pretty easy, just identifying which medications contain glucose. But when I got the PCH formulary, there's 6,405 rows of medications. So that's a lot of data. But working with a multidisciplinary team, pharmacy, nutrition, we were able to take that down to really essentially 3 things. The name of the drug, how common that drug was ordered. We have a data set of 2 years of patients that have been on the ketogenic diet and what's being ordered for these patients. And then we also look at the formulation. So whether that's an elixir, suspension, chewable tablet, et cetera. This is an example of the dashboard that that 2 years of data that we looked at. And essentially, if you focus in this area here, there was 151 orders over the last 2 years, 2015 and 2016. So out of those 151 orders, 42% ended up being canceled due to the alert. So that's kind of the specificity. And when we go live with the project identifying medications and the carbohydrate and the medications, we hope to increase that. The next project that I wanted to talk about was trying to prevent falls by predicting a certain subset of the population that is at risk for falls, and then making some sort of intervention with the fire department through telehealth. So this is a joint initiative between Chandler Fire, Tempe Fire, their community medic programs, and the VA. One thing that they use over at the VA is the Care Assessment Needs Score, and essentially this is a tool that combines multiple factors and can ultimately predict morbidity, mortality for a certain period of time. So as you'll notice, there's a lot of adult diagnoses, chronic illnesses, as well as recent inpatient stays, whether they had palliative care involved. But as you can imagine, there are also predictors of pediatric death and readmission that, as pediatricians, you could look at to predict in this field. So a lot of common things like recent ER visits or recent inpatient admissions, but you'll see some more pediatric specific things like if they've had a NICU stay or more pediatric specific diagnoses such as congenital heart disease. So essentially we took this CAN score and we added a whole bunch of other intelligence to our dashboard, including if they've had a previous fall in the past, if they've had recent inpatient admissions or ED visits, and then we also looked at the medications that they were on, if they were on narcotics or benzos or antipsychotics, whether they've had certain diagnoses that can put them at risk for fall, such as stroke or Parkinson's. Then we weighted those and assigned a certain score to them, so that what you end up with is a dashboard with a weighted score on the far left, and the higher the score, the more at risk this patient is for a fall in the future. And so what you do is you just go down from start to top to bottom and see those patients and try to make some sort of a intervention. So really this is population health, big data prediction, and the clinical value is really in the prevention or timely intervention of what you're doing in the house. We started this project in January of 2017, and since then we've been seeing about an average of 10 patients a month between the two cities. We've seen about 90 patients so far. And these are all the orders that we placed in that time. Consults for OT, placing grab bars in the house, doing medication reconciliation, things like that. So I'm going to go ahead and turn it over to Dr. Hollweg.
Well, thank you. Thank you again for having us this morning. I'm excited to tell you about two projects I've been working on, one over at the VA and one over at Banner Health. So the first one started when the VA here over in Phoenix got their hands on a MMU unit, mobile medical unit, similar to what you have here at PCH. And we were challenged with the idea of how to use this. And we know that being a pediatrician, vaccinations, immunizations, that's paramount. And one of the challenges that we all face is immunization rates. So we know immunization rates are low, and we also know that unvaccinated patients have greater utilizations of services and increased severity of disease. Okay. Now, looking in the background, these mobile medical units and how they're used, we know that they allow for increased access to care. And one study shows improved immunization rates, especially for those more vulnerable populations. And geomapping, it's been used in some circumstances, but in essence, this bottom line, travel distance of care influences negative health outcomes. The further you are from medical care, the less likely you are to get it, and that poses a problem. So that's why we have clinics on wheels to get to our patients. So the question is, if we can use these mobile medical vehicles to improve access to care, but combine that with geomapping and data analytics to really drive home where these vehicles are parked and located. So the methods here at the Phoenix VA, we have 90,000 veterans that this Phoenix VA serves. So we looked at all of those veterans, those that are living, those that have been active within our system for the last 2 years, and we looked at the care gaps, in this case the immunization needs. We later added onto the study hepatitis C and HIV screening for those who haven't been cleared for that. I just want to jump to this slide. So what we did, we took all these care gaps and we plotted it on a map. Okay? So you have one veteran here. He only needs his flu vaccine, so that's one dot on the map. His neighbor needs he has 3 care gaps. He needs all his vaccines and maybe he needs a hepatitis C screening, so that would be 3 dots. So we took that and plotted it on the map. Okay? And those with the red areas here, those demonstrate the highest care needs. Okay? So we hotspotted it. But the big question that you have is, so we have our clusters of different red areas, but where exactly do you park the vehicle within that area? Okay? You're just going to drive to the middle of it and think that's okay? Or you really want to drive home exactly where that is? So that brings us to McDonald's. Okay? McDonald's, Target, Walmart, there's a facility location problem developed over at MIT, and that is using math to really figure out where to park the vehicle. And you ask, how can we do that? Well, we have the addresses of all our patients. All those addresses are mapped to the exact longitude and latitude of where they live. So you take all that information, you put it into this formula, and then you can find out the exact location to minimize the travel distance for each and every patient that you're trying to target. And that gives you an exact spot on the map. Okay? That exact spot can be on someone's rooftop in the middle of a lake. So then you have to look at the map and see exactly what's feasible. So then that brings us to community partnerships. You pick up the phone and you figure out, okay, the clearest parking lot to that event, to that location, you call them up and you see if they're willing to work with your facility, or in this case, the Phoenix VA, to see if to help your patients or to help veterans. So that's exactly what we did. Okay? But since this was the onset of our program, newly acquired MMU, to figure out, we want to see if all this extra effort of picking up the phone and finding these ideal locations was really worth it. Was it worth the effort, or is it just as good to park the vehicle at our nearest facility, what's easy for us? So then we looked at the distances. So we have the optimized events and the non-optimized, and we did 3 of each. Okay, and that's what this map shows. Okay, so within the hotspot target areas, we have 3 data-driven events where we really had a pinpoint location and found the nearest community parking lot to that. And then we had 3 convenient events for us, where we just had it at a local facility. Okay? And then we found out what has a greater impact. Before we get to the results, the other question is, how do we find out, how do your patients find out that you're having an event there? Okay? You can be sitting at home and 2 blocks away. The mobile medical unit could be sitting there, but if you won't know about it unless someone tells you. All right, that's why we developed personalized messaging. Okay, many of our population are elderly veterans, so sometimes snail mail is the best. So we sent them all letters, but we just didn't send them a letter that says we're having an event 2 blocks away. We said, Mr. Smith, according to our records, you're due for this vaccine, and this vaccine, and then for this screening. Okay. We'd love to have you there. We'll be, in a parking lot right near you, within hundreds of yards of your house, in a few weeks. So that's exactly what we did. So we used letters. We also used messaging through the patient portal, My Healthy Vet, and then we used telephone calls. There's a system within the VA not being used, and we used it for automated telephone calls. So they got a call reminding them of the event, and at the end of the message, press 1 if you think you'll come, press 0 if you won't. And this gave us an idea of the workload that we're expecting to staff it and also bring vaccinations. So what we came up with, looking at these 2, optimized and non-optimized, that on average, the optimized event had 40% greater attendance, which means 40% greater service. Actually, one event had a 2.4-fold increase in the amount of veterans showing up and the amount of immunizations that we were giving. One event had, when you're just looking at the vaccination rate, in one day we were able to increase the rate for that population up 15% in a 4 to 5 hour period. And on average, we have about 100 to 140 veterans showing up to these events, giving nearly 200 vaccinations on each of these days. Our last one was last Thursday. We had 120 veterans show up. We gave 140 vaccinations, and that was up in Payson. Okay? So our conclusion, data analytics and geomapping are powerful tools that can be used to improve access to care. Okay? This just demonstrates the work that we've done. So far, we've actually had 12 events with that last event, with 11 more planned for the rest of the year. These numbers are actually, as each day passes, these numbers go up. So actually, we're over 1,000 veterans, and we've given over 1,500 immunization vaccines. And in addition to these services, we provide hepatitis C screening, HIV, shingles, enrollment into VA services. If you're a veteran but not enrolled, we facilitate that process. My Healthy Vet enrollment, and then also we're expanding out to subspecialty care. We have 2 endocrine clinics that we're getting set up for the next few months, and also telehealth services, including mental health telehealth, with, as you would know, that is important within the VA system. And our program has gone so well that the director is looking into getting a second mobile medical unit. Okay, so moving on to next project over at Banner Health. Okay, and it's something that we all face are measures, and within healthcare, we're now with a value-based system. We want to make sure that we're doing everything well and appropriately. For Banner Health, one of the areas that they've been struggling as far as their measures was this one measure. In a 5-star rating system, they're only getting 1 and 2 stars. Okay, this is an osteopenic measure. Women greater than 67 years old to 85, that after they get a fracture, make sure that they're on the right treatment, either bisphosphonates or get a DEXA scan as appropriate. Okay, and we know osteoporosis is an issue. I know that perhaps we don't know in pediatrics, but it definitely is. Bone mineral density is important. So these were the target goals, what they were looking for. So on average, the Banner Health, they were getting in the teens percentage. So that first line is a second star rating, so they were down in the teens, but they wanted to achieve to get up to a 70% to make sure that 70% of these patients were getting the care and the treatment that they were needing. Okay? This is looking more closely at the numbers. So with informatics and data analytics, you can really dive in, and the question that we're asking is not who these patients are, but where they're showing up into our system, because that's where we want to capture them. So we looked at all these patients to see where we should implement our interventions. If we should put our intervention in the hospital, and that was our presumed location, let's just have them come to the hospital and they get their fracture. Let's give them the DEXA scan regardless of how much it costs us, because on the end, we're going to have wins from CMS and repayment from that system. But when we really looked at the data, it seemed that only a fraction, a percentage in inpatient, only 20%, and if you combine that with emergency, up to about 25% will be captured in that set. But if we're trying to get from about 20% up to 70%, that's not going to get us there. So we had to develop multiple interventions. So we had to target both the inpatient, ED, outpatient, and pretty much every aspect that we could. So the interventions that were proposed, the DEXA scan in the outpatient setting, and add that to the order sets when they follow up with the PCP or they follow up with the orthopedic surgeon. Clinical decision support in the ED and inpatient to capture that 25%, and also contracted house calls with portable DEXA scans. So sometimes, similar to the mobile medical unit, we have to go out and to get the patient. And sometimes that's the appropriate solution. Okay? So anticipate outcomes to improve overall quality care, and we're talking about multi-million-dollar return on investment. Okay? So from these projects and the projects Andrew presented as well, we know data-driven healthcare is the road to the future. Yep, here we go. Okay, and do you know who this is? Anyone? Oh, his name's Future. All right, good. All right, good. So moving to the future, okay? So that's what's being done right now, what we just presented. I'd like to just focus on some other areas of informatics that there's potential room for growth, and that's social media and big data, okay? So we know that asthma admissions and asthma in general in the pediatric population is a huge health burden, okay? But what if you know if somebody is about to have an asthma attack or having shortness of breath even sooner and intervene even sooner? So that's why looking in social media data, either Twitter tweets or social media posts, such as Instagram or Facebook, we can look into see what words your patients are using. You know, I'm having shortness of breath, I'm having these issues. Within whatever they're posting, we can have a predictive analytic on top of that that gives us an idea of what exactly we're facing, so that perhaps we can reach out to those patients earlier and sooner and intervene so that they're not showing up into emergency rooms or even being admitted or intensive care as well. So in this case, they achieved 75% accuracy within capturing these patients. Okay? And another area of informatics is natural language processing. Okay? One of the problems with our transition to the electronic medical record is, although it's easier to read, it's not necessarily easier to find information. And it's also not easy for the computer systems that we use to find that information. So natural language processing allows for us to go and dive into notes or dive into radiology reports to find those words and find that information and pull it out into a structured manner so that we can even use Siri and say, show my patient's x-ray with pneumonitis, and it just pulls that information right up, which would improve the workflow and help to aggregate information. So moving on to an overview of our fellowship with Dr. Abbaszadegan.
Thank you to both of you, giving a great overview of applicability of data for the clinician. We are way ahead of schedule. I scared them both into, like, you need to speak much faster, move quicker, but now it's like, whoa, we're going way too fast. So I'll take a little bit more time and discuss the fellowship training and then we'll leave ample amount of time to have a more open discussion between the three of us on all things healthcare, digital healthcare, information, data, and so on and so forth. So the University of Arizona College of Medicine Phoenix Clinical Informatics Fellowship Program lives within the Department of Biomedical Informatics. As you can see from this photo, we do clinical work that involves data and high-tech digital tools. Informatics, specifically clinical informatics, has been a board subspecialty since 2013. So by all considerations, it is relatively new. So by coming out here, speaking to you is a big part of our branding push, is that so clinicians know that we're here to work with you to change how we deliver healthcare. The clinical informatics subspecialty lives within the American Board of Medical Specialties, within the American Board of Preventative Medicine. So this is the block diagram of training. Of course, we will zoom in. So the core education that you get is in year one, the first 6 months. And that's where you learn architectural overview, process improvement, safety quality, clinical decision support, privacy security, and business processes. So these first 6 months is kind of that core-rooted education that the informatician should have. The architectural overview is kind of the understanding of the technical architecture and how things are set up, not necessarily how to fix them. Patient safety process improvement. We get our fellows certified in lean training methodologies, and then they go off into what I consider our core bread and butter, which is clinical decision support. Obviously, privacy security, a huge problem with all the ransomware and exposure of medical records and breaches that we constantly see. So again, a lot of understanding for that. And then one of my favorite months is the last, is the business processes. We are your champion. We represent the clinicians in the executive suite, in the boardrooms, because we understand the data systems and we understand the clinical care front lines. Once you complete this first 6 months, then you go into doing a lot of the project work that you've seen, and as we were clearly demonstrated, the work that was done was just done within 3 months, but you have all kinds of resources in terms of your own coders, people to extract data, and really will let the imagination fly in terms of what you can accomplish. Then we have electives, where you can go to certain sites. I know Andrew, for example, went to Arizona Healthy Connection, which is our health information exchange within the state. Right now, they're both at Hospice of the Valley. So again, it's your imagination, what you want to do. We allow you to do that. Then we have a full-on data analytics course that also takes place. And so in the second year, you then have your continuation of quality improvement projects, again, some more community electives, and then you go off into a long-term project. So what you're going to do for a continuous amount of time. If you notice on the bottom here, there is a little bit of patient care. We like to have some type of continuity, make sure that the patient, fellows are seeing patients. Roughly 15 to 20%. It's not actually required by, I guess, the national informatics councils that make the decision for the fellowship training, but we locally like to see you have some degree of patient care because that is your value. Your peers respect you more when they see you put on the white coat on the inpatient side, or if you're in the clinics, because then you understand the pain points with the health information technology and the data systems. And then they will turn to you to help redesign them, of course. So while that is going on, you have your core education, you have your direct patient care. We also have core content at Oregon Health and Science University. They have a master's certificate program, so you're taking master's level courses to kind of also formalize the didactic component of your education. This is zooming in again on the second year. This is the second half of the second year. Hopefully by here you're exploring where you're going to end up. And so pretty much, as you can see, it's a continuation of the long-term project. So we want you to do something very big, something black belt level. So for those of you that speak lean methodology, that's the whole system-based, not just a local test of change, but all system around, so something on the black belt level. And then you'll be finishing up your certificate program. So just to let you know, we are also a new program. We were the 5th program in the country in that, I think, first or second cohort that landed us in that 5th spot. Right now, as of today, there's 29 programs, which sounds like a huge growth, but think about it. If we're only pumping out 2 fellows a year, that's only 60 doctors in the whole country. We are currently in what is considered as the practice pathway timeline. So you have until 2022 to not do a fellowship and board certify, but once 2022 rolls around, then you will have to complete one of these fellowships. So the goal between all of us is to have about at least 100 training programs in the country, which again would still only pump out 200 doctors. So I think there's going to be less of us than Derm. Is Derm still the most competitive? I've lost track, but I guess, so there'll be less of us and, you know, more competition than Derm. Just to let you know, the practice pathway was just actually extended. It was due to expire this year, but there was a widespread panic in our academic world that we really don't have enough fellowship programs, so that was extended. So, well, the fellows listened very well. We finished way ahead of time. So I had them cut out all kinds of material, but at least we can open it up now, and the 2 of you can join me up here, and we can have a more robust discussion. Feel free to ask anything. If you're frustrated with the health information technology or data systems, we can discuss that too. If there's stuff you like or stuff you want to see, anything, and we have our pediatricians here as well, or you can ask me anything about the fellowship. So, any questions? Yes?
Once you get into the privacy issue, you see that in the headlines all the time. Is that more IT or is that more you guys or combination?
Great question. So the question is, how much do we dig into the privacy and security month, and whether or not the focus is more on IT? Actually, with regards to privacy, security, the focus on the IT perspective will be reviewed at the first month in architectural overview. Once you get into privacy security month, you're working with your privacy officer, and you're doing, basically, we have the fellows do case investigations of privacy breaches and what happened, and if there was some failure with the health information technology or the data management system, something along those lines. We haven't yet had a case with ransomware and Bitcoin, but if it does arise, by all means, we'll get all 4 fellows to investigate that task. So, yeah, so pretty much it's just like clinical care. You're doing a consult, you're doing a case-driven research into what happened. Yes?
Just to add to that, I think one of the newer things that's coming out of security is that with some of the, for example, insulin pumps, some of the technology that patients use, there are safety issues that you can actually, somebody can actually make it deliver more insulin than it should, or somebody can hack into a system that delivers your lab tests out. And so there are security issues that are more than just privacy reasons that are just coming up. And I think that as things move forward, some of the security issues will actually be patient safety issues. So that's something that is new on the horizon.
Yes, thank you. So yes, there's ability to hack pacemakers and insulin pumps and PCA pumps and so on and so forth. So excellent. Thank you for that point. Yes?
Yeah.
I was interested in your falls prevention work. Can you translate that to PCH and also talk or inform us? Is there more work going on in regard to do no harm in general at PCH, and what can you tell us?
Yeah, definitely. Thanks for your question. I would refer you back here. So what they use on the adult side in the VA is the CAN score, which is the Care Assessment Needs Score. And I just created my own pediatric CAN score. So I would, but I would be interested if anybody wants to work on this with me. My contact information is at the end of the slideshow. But so I think looking at some of these factors, I think you could kind of risk stratify the population, look at who's at most risk for like any sort of morbidity, mortality. Can you repeat the question one more time, and maybe I can.
Can you tell us what's going on locally here at PCH in regard to falls, and then are we looking at a do no harm project that would expand the work further?
Do no harm, is that like a, can you expand on that a little bit?
What's going on in hospitals nationally where not only are we looking at falls, but prevention
I see. Yeah, you know, I would defer to Vinay Vadia on that more so. I'm not as familiar with what's going on as far as like an inpatient fall prevention. Is that like within the hospital? This project was looking more at the outpatient setting and falls in an outpatient setting. But yeah, no, sorry, I couldn't be. Yeah. Hmm?
Yes. Yes, absolutely. So that all is data, information, provider report cards, a lot of these types of key buzzwords. What quality are you providing? So this is a challenging topic to understand well. And I myself, every time I talk about it, have to backtrack a second and think about, you know, how do I even present this? So as physicians, the word report card is damning. It's bringing us back to the competition days of, oh my God. But that is actually not what is the goal. The goal is not to pin us against one another. The goal is to say that, look, we have determined that if you get aspirin within 5 minutes of you showing up into an ER and you're in the middle of a heart attack, sorry for the adult example, but that the outcomes are better. So what's going to happen is we're going to start measuring you guys in terms of meeting that goal. Are you getting it to the person within 5 minutes? And if it takes you 6 minutes, then your quality gap is 1 minute. So again, it's not to pin you guys, it's to get us into the 5-minute group. But you guys all know that, well, it's not just me, it's the whole team. And absolutely, you placed an order is only one component. You identifying the clinical syndrome is one component. But there's other elements. So coming back to quality and outpatient, and I'll defer to these guys to give a PEDS example. But if you're diabetic, you're supposed to have a foot exam and an eye exam. And so, again, if you talk about a quality report or physician report card, you know, for example, one person might have 70% of his patients have those compliance done, another has 90%. The quality gap is 30% for one, 10% for the other. So the intention is to get us all following standards of care, not all necessarily being told what to do. Can you guys give a PEDS example?
So the first piece example that comes to mind is just vaccinations. If you know this provider is getting 40% of the flu vaccinations, and this provider is getting 60%, how can we get the providers that are falling behind up to the rest of the group? And I think if you don't know where you're at, I think the value is if you don't know where you're at, you don't know where to focus your efforts. And so I think rather than having it be a competition, I think it's more so trying to tell the provider where he or she is at and how to improve.
And so to just come back, you were asking if that's within our realm of informatics, and the answer is absolutely. We can help you organize how this information is viewed in what we call a dashboard, just as a dashboard of a car tells you your revolutions per minute, speed, and gas. So what information is useful to you as a program director, and what information is useful to you guys as residents to just gauge where you're standing with regards to this. And wherever you see those quality gaps, those are the patients you have your ancillary service team target to create the visit. So yes. Any questions? The residents, trainees, nothing? Anyone interested? Forget GI. It's all informatics or bust now. No? Okay. Anything else? Anyone else? We have our other two fellows, by the way, Dr. Nia and Dr. Wen. They're our first-year fellows, and all the way to the right, we have a visiting resident from Mayo Clinic. So if you have even an interest, or even if you don't want to do the fellowship, but you want to learn more, we do allow for resident rotations, and we will expand our role with med student rotations as well. But as of now, if you'd like to rotate with us, you may. Anything else? Anyone else? Okay, 15 minutes early. Enjoy the day.